Good afternoon, everyone, and welcome to the spring edition of the Behind the Scenes lecture series. I'm Louise Aspin, and I'm the Senior Vice President and Chief Development Officer for Toronto General and Western Hospital Foundation. I'm delighted to be your MC today, and I want to start by thanking all of you for joining us today in what's a rather different format than we are used to. Normally, we're all in person, but in these times, we're living quite virtually. So we're very grateful that you can all be with us today from your own socially distanced locations. And perhaps you've joined us for one of our recent COVID-19 virtual Q&A live streams. Today, we're thrilled to have the opportunity to focus on some of the amazing work happening at the Donald K. Johnson Eye Institute at UHN. We're committed to providing you with the most up-to-date information about our healthcare system. And this afternoon's event is our way of thanking our donors for their tremendous generosity and support. Our doctors, researchers, and scientists would not be able to pioneer new discoveries without you. Our behind-the-scenes lectures give you a snapshot of all the amazing work and innovative research that is happening at our hospitals. Today's presentation is no exception. As many of you know, Toronto General Hospital was ranked for the second year in a row as a top 10 hospital in the world by Newsweek. We're actually number 4. This ranking references 1,000 institutions from around the globe and across 4 continents. Innovations that are taking place in our hospitals are helping more Canadians and people around the world live their best lives. And donors like you make that possible. Today, we're fortunate to have 2 incredible visionaries from the Donald K. Johnson Eye Institute with us to present on their latest research and innovations. It gives me great pleasure to introduce Dr. Valerie Wallace. Valerie is co-director of the Donald K. Johnson Eye Institute and holds the Donald K. Johnson Chair in Vision Research at UHN. She is a world-renowned expert in her field, and we're thrilled she could be here today to give us an overview of what is happening in the Institute. Dr. Wallace, welcome.
Thank you very much, Louise. It's a real pleasure to be here today and to welcome you all to this behind the scenes this afternoon. So the Donald K. Johnson Eye Institute is a big, busy place. We have over 85,000 patient visits a year, 4,200 and plus surgeries performed every year. And that's carried out by a dedicated team of 54 clinicians, researchers, fellows, and ophthalmology residents. The reason we're so busy is that over 5 million Canadians live with some kind of eye disease, and the number of cases of blindness or partial sight doubles after age 40 and triples after age 75. So it's a real age kind of related problem. And because of our aging demographic in this country, it means that more and more Canadians are losing their sight at an alarming rate. So here at the Donald K. Johnson Eye Institute, our team of researchers and clinicians and trainees deliver world-class treatment. We produce high-impact research, and we develop therapies to prevent disease, improve outcomes, and ultimately restore vision. We're at the forefront of innovation in research and care, and we work collaboratively to support patients suffering from debilitating diseases and visual injuries. Our scientists work every day to understand how vision works, both in healthy and diseased eyes, and our ultimate goal is to eliminate blindness and vision impairment in people. The Donald K. Johnson Eye Institute spans research into the molecular and cellular mechanisms of retinal disease, to developing new approaches for retinal health assessment and vision rehab today for patients with blinding eye disease that you'll hear about this afternoon. And it's through the support of donors like you that we've made significant achievements in cutting edge and state-of-the-art vision care. And here we're lucky enough today to hear about that cutting edge research from Dr. Michael Reber. Dr. Reber is exploring the potential for virtual reality, not computer games this time. It's a 360-degree immersive experience, much like the ones used by athletes, doctors, and pilots, but this time to be deployed to be used in low vision patients to improve their field of vision. And to our knowledge, he's the only researcher in the world doing this kind of groundbreaking work. Dr. Reber joined the Eye Institute in April of 2018. Prior to that, he was an associate professor at the Institute of Cellular and Integrative Neurosciences in Strasbourg. Before that, he did a PhD at the Paris Diderot University in France and postdoctoral fellowship training at the Salk Institute in California. His research program looks at how the brain's visual network, which is maybe the simplest way to think of it, is a connection of or webs of cells that connect with each other so that you can process what's coming in from the eye as vision in the rest of your brain and interpret your world. And he uses a combination of experimental and mathematical models to understand how this system develops and is organized, is maintained. And so without further delay, I'm going to hand this presentation over to Dr. Michael Reber to tell you about some of the really exciting work that they've been doing in low vision patients with virtual reality. All right, take it away, Michael.
Thank you, Dr. Wallace, for this kind introduction. And thank you all for spending some time to listen to this presentation today. Good afternoon, everyone. I'm really honored to be with you this afternoon and very excited to share some early results we obtained on what we believe is a truly unique but also groundbreaking technology that we have been developing over the last 2 years at the Donald K. Johnson Eye Institute with the goal of helping low vision patients and to improve their visual perception, but ultimately improve their quality of life. So I will spend some time telling you the story of the development of this technique and this technology and its impact on patients. And it all started when I came across some numbers some time ago, especially that learning that every 12 minutes a Canadian is diagnosed with visual impairment, that over 5.5 million Canadians have eye disease, and this number will double in the next 20 years. Moreover, for 69% of Canadians, vision loss is the most feared disability. So these numbers just struck me. I'm a basic neurobiologist, and when I found out about this, I decided that I needed to be involved. So I looked a little bit further, and I'm going to show you some important numbers because this has a expense impact on the economy. 19 billion is the total cost of vision loss in Canada in 2012. And this is going to go up to 30 billion in the next 10 years. This is the number one healthcare cost, 8.6 billion direct costs. This is way in front of cancer or cardiovascular disease. 4.4 billion correspond to the loss of productivity. And on top of that, the cost of suffering, the burden of disease is another 11.7 billion. So definitely vision loss and vision impairment strongly impacts and represents a huge financial burden for a society. So what are those diseases that are leading to vision loss and vision impairment? Among those, 11% represent age-related macular degeneration, 16% represents cataract, 4% represents diabetic retinopathy, 3% glaucoma. And the 66% remaining include different eye disease such as retinitis pigmentosa or retinal cancer like retinoblastoma, but also other conditions that impact the visual system like stroke, cancer, or neurodegenerative diseases. So I'd like you for a minute to imagine what are those patients experiencing. So if you have a normal vision, a normal sight, this is what you would see standing on the Toronto Island and looking towards the Toronto downtown and this beautiful skyline. So patients with age-related macular degeneration will experience this black spot in the center of their visual field. Patient with cataract will have this blurry and dull vision. Patient with diabetic retinopathy will have patches of visual information missing in their visual field. Patient with glaucoma will have a shrinking of their visual field with impaired vision in the periphery. Retinitis pigmentosa patient will experience this tunnel vision, and hemianopsia patient will not be able to consciously see either the left or the right side of their visual field. So how does all these diseases impact the daily life of those patients? AMD patients, for example, have difficulties reading or cooking. They have issues with face recognition. Going downstairs becomes challenging and potentially dangerous. Taking public transportation, going around in busy and crowded places and areas is extremely demanding and exhausting. And also going for shopping becomes complicated, as well as the sports and leisure and hobby are all strongly impacted. So definitely low vision prevents healthy living and aging. Patients with low vision have 3 times more chances to be depressed. The risk of falls is multiplied by 2, and the risk of hip fracture is multiplied by 4. The risk of social dependence also doubles. So clearly, low vision strongly impacts quality of life in those patients. So remember, I mentioned all those eye diseases. So except cataract that can be cured by replacing the damaged lenses, all the other diseases cannot be cured so far. So they can be slowed down, the progression can be slowed down, eventually stopped, but once you have the symptoms, there is no coming back. So together with my colleagues at the Donald K. Johnson Eye Institute, we work on trying to find out what's going on in those diseases, trying to identify the pathways that are affected, the molecules that are defective, and eventually find ways to replace them. So there is hope, but there is hope on the long term. So in my lab, we decided to take a parallel approach, and someone wondering, well, if there are no cure for now, can we find a way to help the patient on the short term? Can we design something that low vision patients can benefit from? And so our approach relies on a basic paradigm, which is your brain can be considered as a muscle. Your brain can be trained. For example, training your memory has been shown to slow down the symptoms of dementia. So similarly, the visual system can be trained. You can stimulate visual perception, and this is called perceptual training. And to make it very efficient, we use virtual reality. So let me define first perceptual training. So perceptual training refers to long-lasting changes in perception due to neuronal plasticity or neuronal remodeling resulting from practice and experience. So this is typically what, if you are learning to play a new instrument or learning a new sport, of course you need to acquire the technical skills. But at the same time, your brain is also training and you are acquiring perceptual training. For example, for given sound or for a particular touch or feeling. Virtual reality corresponds to an artificial environment which is experienced through sensory stimuli such as sight and sound provided by a computer, and which one's action, your action, the patient's action, can actually influence the environment. This has been used for quite a long time to, for example, train pilots, or also more recently to train surgeons. So virtual reality and perceptual learning have been used in rehabilitation medicine for quite some time, and in particularly in stroke patients, to restore balance, gait, upper limb, and hand function. It's been shown that a minimum of 15 hours of perceptual training using virtual reality has a beneficial effect on hand function and daily living activities. However, virtual reality has never been used in low vision patients so far. However, perceptual training and visual system training is used currently in low vision patients. And this is performed here at Toronto Western by the low vision rehabilitation group with patient having age-related macular degeneration. And the goal here is to make available reading again for those patients. So here the ophthalmologist actually use this device to train the patient's eye and visual system to actually use a different part of the retina to be able to read again. So as you may know, age-related macular degeneration, there is a degeneration of the center of the retina, which is called the fovea, which is the high-resolution part of the retina, which is the one that you use when you're reading or face recognition. So this area is degenerating in this disease. So the idea is to use a different area, which is just right next to this degenerating area, and teach the brain to use this new fovea to read. And so this requires some training, but after some time, the patients are able to somehow remove this blind spot from the center of their visual field and use this new fovea location in the retina to be able to read or having face recognition again. Similarly, in a myopia patient, there is audiovisual perceptual training going on to restore visual perception in the blind hemisphere. So, for example, here the patient is seated in front of this very large panel made of LED lights and associated sound speakers. This can only be performed and provided in a clinical setting. So the patient in the training phase will respond when the patient feels or perceives a stimulus, which is composed of both LED light and corresponding sound. And the testing phase, you remove the sound and you just use LED light. And it's been shown that with a minimum of 20 hours of this audiovisual training, the patients are able to perceive visual stimuli in their blind hemisphere. So this indicates two things, that sound can help vision. And those are things we knew from like more basic neuroscience and basic neurobiology. The visual system is not working independently. It works tightly with, in coordination with other perceptual pathways, and in particular in humans, the auditory pathway. Audition and vision works together in humans to allow detection of the elements in your surroundings. So similarly, we decided to develop such audiovisual stimulation protocol, but we decided to do this in more advanced and high-tech device. And for this, we are using the Oculus Go virtual reality headset. So I have one here in the lab, as you can see. So those are typically the device the patients are using. You put that on your head like this. It's fairly easy to use. And you will use this for your visual training, your daily visual training. So this device, together with its laser pointer and the NeuroFi application, allow us to design dynamic visual training protocol in a fully immersive and realistic environment. So we are using this application NeuroFi, which was originally designed by a Swiss company. The goal being to train the visual capacity of professional athletes. So the idea was to increase their visual detection level, their visual tracking speed, as well as their spatial attention. And a few studies have shown that such training, for example, increases the pass accuracy in professional soccer players. Or, for example, that visual tracking speed in basketball correlates with the performance on the field, like particularly like steals and assists. So we were wondering, well, if professional athletes are able to increase their visual capacity using this device and this application, why couldn't we provide this to low vision patients? As long as you adapt the visual training protocol to the visual capacity of the patient. Moreover, this device is extremely useful because it's remotely controlled and it's standalone. So the idea and what we've done is that we basically provided this device to the patient to take it home. And then the patient was training from home. And we were able, using the computers in the lab and using this particular interface, to control directly the stimulation protocol through Wi-Fi. And each time the patient was performing the training, we receive real-time data like this. And this tells us whether the patient performed well or not on the training protocol. And so we adjust the training protocol on the patient's performance. So we can go back to the interface, modify the training protocol, send it to the device for the next training. So this allows us to create a very efficient training protocol, which is really adapted to each patient. So you remember I mentioned those diseases, and if you look at it carefully, they are all affecting the visual field. So the basic idea here is to say, well, can we find a way to train the visual system and the brain so that it maximizes the use of what's left of this residual vision? You know, can we make up most of what's left of this healthy vision? So for this, we designed a few training protocols. And here is an example of one protocol, or one training program that we recorded from inside the Oculus Go. So this is what you would be seeing if you would wear the Oculus. So in this particular program, you have 8 yellow balls. One of the balls will turn red for a few seconds and will turn back to yellow again. And everything is going to move. And after a few seconds, it's going to stop. And you are supposed to select with your laser pointer what is corresponding to the target. So the way to do this, of course, and you as a patient, your task is to follow this ball. So you would follow this ball using vision and tracking, but you will also be able to use this ball by sound. So what we did is that we associated with the target a so-called spatial sound. So if you would wear the Oculus Go and even close your eyes, you would be able to locate the ball in space just with the sound. The idea is to train the patient to combine image and sound, so to increase higher tracking and detection of elements in the visual field. Let's move to the second exercise. We can make it a little bit more complicated by, for example, adding 2 different targets, one green and one red one. This is, of course, much more challenging for your visual system. And the trick is that you would follow with your eyes the green target and use your spatial attention to follow the red target. We can make this a little bit more challenging and, for example, add some sort of relevant or realistic background that will challenge your visual system a little bit more. So here in this case, you would just look around in your Oculus Go and you will see the entire plaza of this city around you. And then you will be performing the same type of exercise on a this realistic background. Same thing here to make it even more complicated and even more realistic is to, so we recorded a video, a 360 video at the corner of Dundas and Spadina here in Toronto. And so the idea is to create a real life situation. So you would be performing those visual tasks on a moving video that shows you the activity or real life at an intersection in Toronto. So I'm now going to show you a summary of the results we obtained with one of the patients following this typical training protocol. And so this patient was diagnosed with left homonymous hemianopsia. And here is an example of one of the visual tests that we are using to evaluate a visual field in those patients. Tests that are used by the low vision clinic. So this is called the Esterman binocular visual field analysis. What is represented here is the visual field of the patient. So the center of the visual field will be represented here in this graph. And as you move to the sides, you would move in the periphery of the vision. So this patient, the white dots here represents the LED light that can be perceived by the patient. The black squares represent the LED lights that are not seen or not perceived by the patient. So in this case, the patient doesn't see the left part of this visual field. And this can be superimposed with what the patient is actually seeing. So in this case, the patient is unable to see the left part of the visual field. So I'm going to show you some of the data we obtained after training. So this patient followed a 3 months training protocol, 15 minutes of virtual reality training every other day for 3 months, which altogether represents roughly 12 hours of training. I'm going to show you some data before training and some data after the end of the 3 months. So let's start with what we measured, contrast sensitivity in the right eye OD or the left eye OS. As you can see, before treatment for both eyes, the value is 1.94. After treatment, this value goes up to 2.41. So there is a significant improvement. So what is contrast sensitivity? Contrast sensitivity is your capacity to distinguish an object from the background. If you have low contrast sensitivity, this is what you would be seeing from looking at stairs, for example, or looking at pavement. If you have good contrast sensitivity, this is what you would see going in those stairs or on pavements. So contrast sensitivity is extremely important to allow you to distinguish texture, to allow you to step down a curbside or sidewalks. We also looked at reading speed. Reading speed after treatment dramatically increased from 109 words per minute before treatment to 160 words after treatment. And this is very likely due to an increase also or an improvement in fixation stability. So fixation stability measures the deviation of your eye when you are fixating to a specific point or your point of focus. And you want this number to be as low as possible because this measures the deviation of your eye. So this patient was already doing quite well because those data, those numbers are close to normal, but after the virtual reality treatment, it improved even more. So fixation stability, you want it to be as low as possible. If you don't have a good fixation stability, this is what happens. You are unable to read. So you really want to have good fixation stability to be able to read or to recognize faces. And finally, I want to show you, if you remember what we used at the beginning to diagnose the patient. So this is the Esterman binocular field of view analysis before treatment. The patient was able to detect 66 points. So after 3 months, the patient was able to detect 75 points among 120. This is a 15% increase. So, and remember, this is after 12 hours of training. So we already see a strong effect, which is extremely promising after just 12 hours. And we believe this is due to the fact that we have this very, very specific, tailored program that stimulates the visual system of the patient. Remember, I showed you that for hemianopsia patient, for example, as to now, a minimum of 20 hours were required to see some effect. Here, after 12 hours, we already see an effect. But more importantly, this patient was able to detect new points close to the center of vision. But what is absolutely amazing for us, and that was very surprising to come in that early in the treatment phase, is that this patient is now allowed to perceive visual stimuli far out in the visual field, which is extremely promising. Remember that this field was completely blind. So in conclusion, I would say that this tool we are using is extremely powerful. So it allows us real-time management and real-time data acquisition. So this allows to tailor the training program or the training protocol to the patient's performance. So we make this training protocol extremely efficient for the patient. So this is equivalent to a personalized treatment or even personalized medicine. So we are going back and forth, between what we do in the lab and what we provide to the patient. So this bench to bedside and back to bench system where all the time we have this permanent interaction between the device used by the patient and the data we acquire in the lab, and then optimizing the training again. So ideally, if you can stabilize vision, if you can increase contrast sensitivity, but also increase visual fields, well, very likely you will make all those risks disappear and bring the patient back to real life, bring the patient back to self-dependency. This patient will now probably be able to go out again, feel comfortable enough to go in busy streets, busy areas, or eventually take public transportation and so on. So on the long term, this definitely will also decrease the burden of disease and the indirect costs, so benefits also the entire society. The future for us is very exciting. We are about to start a pilot study on patients with age-related macular degeneration, and we hope we can start this really soon. The idea is to combine the new fovea training that I mentioned earlier with AMD patients performed here at Toronto Western by the Low Vision Clinic, together with the virtual reality stimulation. The idea is to see whether the combination of those two rehabilitation techniques improve even more visual perception in the patient and quality of life. Of course, we would like to test that on glaucoma patients or diabetic retinopathy patients or stroke patients. I was amazed to learn that 10% of patients have permanent homonymous hemianopsia. So this is an amazing number. And it is well known that the earlier you intervene, you start a rehabilitation protocol, you increases the chances of recovery in stroke. But to continue this, we need resources. We need more of those devices. We have also been contacted by doctors at SecKids that are very interested in starting a pilot study on hemianopsia patients from SecKids, particularly teenagers, from the brain tumor program. I wasn't aware of it, but a majority of those children have visual deficits due to cancer or cancer resection. And there is no low vision rehabilitation protocol existing for those children. So we are very excited to start this with people at sick. As Dr. Wallace mentioned at the beginning, for now, we are the only one in the world using this and working on that project. So we have this leadership, and we want to keep this leadership. So what we need is to be able to gather as much data as we can, as much evidence as we can, to really make this approach something strong. And in an ideal world, and my ultimate dream, I would say, would be that this tool becomes some sort of standard of care for low vision patients. So to make it available to every patient, to improve visual perception and ultimately quality of life. So of course, this work is not is a group work, and I want to thank the ophthalmologist from the low vision clinic, running and working all the clinical analysis, as well as scientists at the Donald K. Johnson Eye Institute that are implementing the virtual reality device. I also, of course, want to thank the institutes, the Donald K. Johnson Eye Institute, for giving me a chance to start this project when I arrived 2 years ago, the Krembil Institute, the Tomorrow General and Western Foundation putting together this event. And thank you very much, Louise. Thank you, Tessa. Thank you, Jonathan, Kimberly, and many others that helped putting these events together. I want to thank Neurofy also, which is this Swiss company. We are collaborating now to elaborate a medical version of Neurofy. And of course, I want to thank you, donors, for your generosity. I mean, this type of work wouldn't be possible if we wouldn't benefit from your generosity. Typically, the conventional funding sources wouldn't support and wouldn't fund this type of research that early in the research process. They will probably once we have those pilot studies, once we have those preliminary data. But to get there, we need your support. So for this, thank you very much. And thank you for your attention.
Thank you, Dr. Reber. We really appreciate your time, and we appreciate this incredible information. And thank you, Dr. Wallace, as well. I'd now like to just take a couple of minutes to read a testimony from a 28-year-old patient of Dr. Reber's. And we're going to refer to him as Charlie. So now in Charlie's words, at the age of 8, I was diagnosed with brain and spine tumors. The primary site was an optic chasm where the optic nerves connect to the brain. I underwent 2 years of chemotherapy, followed by another year when I was 19. The location of the tumors caused my vision to be impacted. For as long as I can remember, I've lived with a deficit in my left peripheral vision. This is something I was always told could never be fixed, that I would have to live with for the rest of my life and just have to learn to compensate for the deficit. So I did, looking to my left more often than my right, though this didn't always prevent me from bumping into objects or people while walking. I thought this was my new normal, and I would live the rest of my life with the left side deficit. You can imagine my surprise when one of my doctors told me about the work being done by Dr. Reber. I had doubts anything could work, but gave it a try anyway. I was told to use an Oculus VR headset every other day with a specialized program to assist my peripheral vision. To my surprise and excitement, after 3 months of doing this regimen, I could feel the positive effects from the VR headset. I am now much more confident walking around outside, bumping into things less, and can certainly notice the improvement in my left peripheral vision. I'm extremely thankful for everything Dr. Reber has done to improve my quality of life, especially after being told this is something that could not be fixed. I'm also grateful to donors such as yourselves who helped to make this research possible. My life has been changed for the better as a direct result of Dr. Reber's work, and I will forever be grateful for that. So I, first of all, really want to thank Charlie for sharing his thoughts with us and his gratitude and his experience. And Dr. Reber, this is an incredible statement about the impact of your innovation. Would you like to comment on Charlie's experience?
Well, I mean, it's really touching, and I mean, this is, I don't know what to say. I mean, that's great. I mean, this is like our ultimate goal. That's my ultimate goal. I mean, if patients like Charlie are happy with it, I mean, and this has changed their life. I mean, this is something fantastic. This is really something fantastic, and it's very touching. And then I hope we'll have more of those soon.
Terrific, thank you. And so now it's my pleasure to open up the floor for a 10-minute Q&A session. And if you'd like to submit a question for Dr. Reber or Dr. Wallace, you can do so by visiting the Slido link found in your confirmation email. We have received a number of questions already, and we'll do our best to get through as many as possible. So the first question, I think I can direct it to both of you, is how has COVID-19 affected your research or this treatment? Are you still able to connect with patients? So maybe start with Dr. Reber first and then go on to Dr. Wallace.
Yeah, sure. I mean, this is an excellent question, and that's a little bit the beauty of this approach. I mean, we have been able to connect with the patients, and the good thing is that the patient had no interruption in their treatment. We were working from home, basically, reprogramming, readapting the stimulation protocol or the training protocol to the patient's performance. So as long as the patient is training at home, we receive data and we can adapt. So I must say, COVID did not affect the treatment of the patients.
And what about Dr. Wallace? Have you been able to connect with patients in your research studies?
You know, it's kind of funny. Most of my research doesn't directly involve patients, but something that I have noticed that's happening is I get a lot more queries from patients about my work. And I think asking, so for example, we have podcasts talking about our research through UHN and other online platforms. And I think because people are home and have time, they're actually finding these things and listening to these things. And so in fact, it's kind of been, it's been a nice surprise out of this COVID that I actually engage more with patients to tell them about what I'm doing and where they can get help or learn about, you know, the problems they have. So I wouldn't have expected that kind of benefit from COVID because we're working from home. We're still doing research, but mostly at home. A lot of writing, but there's more patient engagement even for somebody like myself who is really a basic wet lab researcher. So it hasn't all been bad.
Terrific, thank you. And who qualifies for Dr. Reber's VR training?
Well, I would say any low vision patient. I mean, you can be referred to the low vision clinic here or contact the low vision clinic here, and we'll be happy to include you in studies if, of course, you are touching some of the minimum requirement that we have in terms of vision and eventually comorbidity. But I must say anyone qualifies for virtual reality training.
Terrific. And what kinds of doctors will have access to this technology for use with their patients? So is this something that you plan to roll out through the healthcare system?
I mean, ideally, if we manage to reach that point of making this tool as a standard of care, yes, of course, we would love to do this. But this is, I mean, there is a long way to go there, I guess. Lots of studies are still needed to validate this approach. But ideally, yes, this is what we would want. You know, we want, if this proves to be useful, if this proves to improve the visual perception of low vision patients and increase and improve their quality of life, we must make it available for all of them, definitely.
And so would you see this in a general practitioner's office or purely ophthalmology practice?
I think this can be moved to general practice as long as we can come up with given protocol based on the results that are obtained. You know, this can be provided by a general practitioner, but then the evaluation and of course, visual evaluation will be performed in the ophthalmology clinic or low vision rehab. Yes.
Great. And how quickly would someone using this technology notice an improvement in their vision?
Well, the patient's testimony, these patients may eventually answer, but what we have seen is that with, I mean, even less than 12 hours actually, because the data I presented were like before treatment and after 3 months of treatment. So after 12 hours basically of training. But we had intermediate data that I didn't show you. But we already observed some improvement at 4 or 5 hours of training. The thing is, the patient might notice it. The thing is, these improvements will not be stable over time. So they would be recently acquired. And so if you are not keeping the training, you will very quickly lose these improvements. So the idea is not only you want to acquire them, but you want to sustain them, right? You want to keep them as much as possible. And now we are in this phase where we are trying to investigate how many training would you need, let's say once a week or once every other week, to some sort of maintain the improvement that you acquired with like the more intense part of the training.
So this seems like very interesting and high-tech equipment that you're using. How are you funding this? How is the hospital funding this?
So for now, it's a research fund because it's still at the research stage. So far, we will be running those experiments with research fundings. After that, I don't know. I mean, I don't know how the hospital is gonna fund this. I have no idea. But for sure, for the beginning and to gather enough data, this will be running through research funds.
And Dr. Wallace, do you have any comment on that?
I have to unmute myself. So yes, as Dr. Reber says, right now it's a research study, and so some of those costs are being covered through a Krembil Research Institute funding competition. That's exactly the kind of competition or stipulates that the research has to be at the forefront of basic science and clinical research. So clinicians and basic scientists working together. And that competition was, several grants came in, and Dr. Reber's grant was successful and is going to be funded. So now where that money comes from is basically from philanthropy, it's donors. Because a lot of times it's like kickstarting an initiative. You need some funds to get it started. And the Krembil wants to support these kinds of initiatives. And the plan is that once there's more data, as Dr. Reber has said, that there will be enough data and enough evidence that this is promising that it could go to, for example, a federal granting agency to get a much larger grant to support a much larger study.
Terrific.
Yeah, I just want to mention that indeed the first section of the future slide was related to these funding we obtained from Krembil that allowed us to actually buy 2 more of those devices plus the licenses and think about putting together this virtual reality study on age-related macular degeneration patients.
Michael, just how much does one of those virtual reality units cost so that, you know, a patient could take one home and train with it? How much, how much does one cost?
Yeah, the entire system is actually around 7,000 to 8,000 Canadian dollars. We might bring down these costs a little bit. With this, we have a full control of the device. It's a lifetime use. I mean, that's a license that allows us to, you have one license and you use it however you want. You know? So we have full control of the device. we can use it as long as we want. I mean, this can be used intensively, and we just buy the Oculus and we download this application, and all together with the computing aspect in the lab and so on, it's around yes $7,000 to $8,000 per equipment, per device.
Right. So to actually have enough data collected to go for funding from the Canadian Institutes of Health Research, how many patients and devices would you need data from to have a really good set of pilot data?
Well, yeah, I mean, the more device we have, the more patients we can include, and the faster we will go with the data. I mean, if we have only 4 of them, we can spread them. But I mean, for example, for this pilot study, we are planning to have around 40 patients, 40 to 50 patients. You know? If we have 20 of these devices, we can make 2 groups, right? And we run 2 groups like this. If we have only 5 of them, well, then things are going to become a little bit more complicated and challenging to put together. And for sure, it will take a lot of time to process and analyze all those 50 patients.
Okay. So you'd like data from about 40 or 50 patients. So how fast you collect it depends on how many devices you have.
Well, yeah, absolutely. We can run them all together, or we have to run them in several groups.
And how many devices do you currently have?
So far, we have 4 of them.
Okay. Okay, thank you. Can you talk about some of the mitigating factors that may affect the success for the patient? You know, for example, age or mental health or environmental.
So this is something we've been working on actually, and I must say age doesn't seem to be a mitigating factor. We had one patient very early in our testing process that was over 80-year-old. So and this patient, we originally thought that it would be difficult for elderly people to adapt to this and wearing these masks. The fact is that this patient really liked it and was very excited to use it. So it seems that there are no age limit to use this device. Mental health factor may be involved. There is some literature coming out now for the use of virtual reality and perceptual training. So we need to go back to this literature, really follow up what's going on. And environmental factors, so far, we haven't identified any that could affect the use of this device.
Is there anything else that might impact the success?
Well, one thing is the patient would need to have a Wi-Fi. So and the quality of Wi-Fi is not a big issue because everything is loaded into the VR. So what we change are only a few parameters. But the basic and the core of the application is in. We are not transferring those data by Wi-Fi. What we transfer is a very small amount of data, and what actually the patient is sending us, so the device the patient uses sending us, are just Excel files, just numbers. And this takes no space. It's like a few KB of data. So this wouldn't impact, for example, the costs of a Wi-Fi plan from home or whatsoever.
So it sounds like it's very accessible to most of our patient population.
Absolutely, absolutely.
So like any kind of virtual reality game, do they get to choose their backgrounds?
We have multiple backgrounds, and the background is really depending on what we want to do. So background actually is part of the training. Unfortunately, I wasn't able to show you the videos, but the easiest aspect is black background, so no background. So you're really working on the visual tracking. But then we are adding backgrounds in there to challenge the visual function and the visual processing. And well, we have multiple videos. So the patient, we want to have something like realistic. So unless we live on a beach in the Bahamas and we don't have such backgrounds yet, but we'd be happy to go and record some videos from those beaches there. It's going to be more real life, realistic environments, such as the one I showed you, like intersection, for example, or curbside's view, or views from busy areas or so. So no, the patient will not be able to choose the scenario.
Okay, thank you. And are the patients actually being treated with other therapies at the same time as this virtual reality headset?
So far, the data we obtained, it was only the virtual reality headset. It wasn't combined with any other visual rehabilitation therapy. But as I mentioned in the future perspective slide, the first step for us now is to test whether this rehabilitation using virtual reality could fit with what's already existing for age-related macular degeneration related to the reading and the new fovea relocation using biofeedback, which is performed here at Toronto Western. So the idea is to combine it. And we believe that indeed, I mean, combining two different vision therapies can be only more helpful and much more efficient.
And in your presentation, you mentioned or you referred to athletes using virtual reality to train. And how does this differ from how you're applying this treatment to your patients?
So yeah, athletes that are using this training protocol are actually, so we have, I mean, it's almost infinite, the options we have to train the patients. I unfortunately, as I said, wasn't able to show you the video. We only have a few, I only showed a few of the training possible, but it's like almost infinite. So we can train different part of the visual system, different aspects of the visual system, like covert attention, overt attention, tracking, and so on and so on and so on. The athletes actually use the exact same paradigm, I would say, except that they use it much faster. So the speed is like multiplied by 3 or 4 compared to what we could experience with the patients here. The number of targets to follow is also much larger. And the backgrounds are also different because we can, I know this company is implementing backgrounds that are realistic to or relevant to the actual athlete's sport, right? So if it's basketball, you may have a basketball court. If it's a hockey, ice hockey, you have a hockey ring, and so on and so on and so on. So it's basically the same principle, but it's just adapted to the patient's visual ability and capacity. So this means less targets to follow and a slower movement, I would say, and also maybe a shorter duration of the stimulation in terms of the task itself.
Thank you. Are there any challenges with the headset? Any drawbacks that patients experience?
So far, but we haven't had many patients, but so far it's okay. And we haven't had any complaints. Now, it's been reported in the literature that there might be some issues with virtual reality, and it can create some sort of seasickness, I would say. You know, you may feel noxious a little bit. So there are now some protocols to evaluate this. And so, for example, if now we have a patient coming to the clinic that would like to participate to one of our studies, the patient will, for this first inclusion visit, would test the virtual reality headset. And then we will have questionnaires and different ways to evaluate how the virtual reality may affect the patient. So for sure, when you've never used one and you use it the first 2 minutes, you're feeling a bit noxious. And this is normal because your visual system is not used to it. Now, after 1 or 2 trials of like 10, 15 minutes, you're totally fine. Now, there are some people that probably may be more sensitive to this. So we need to be careful and we need to make sure that the patient will be able to use it in a very safe way.
And how do you see using this treatment? You mentioned stroke patients and using this for that sort of comorbidity. Would there be any modifications needed with the program?
So it all depends. So for sure, for example, like stroke, if your visual field is affected, well, the goal of this virtual reality training program is some sort of restoring of visual perception in the blind fields. but you must also be able to actually use the pointer to select the role. So there must be also some sort of motor skills available. The training is performed seated. The patients will not be standing whatsoever. So generally what we make sure is that the patients are comfortably sitting in an armchair or something like this. They feel relaxed, and then they can perform the study. Modification itself in the program, we will adapt to the patient's visual capacity. So we will quickly find out whether the training that we are offering for this particular patient is too challenging or too easy for the patient, and then we will adapt accordingly. So modifications will be indeed related to the patient's performance, but there will not be structural modification, I would say, to the system, because this is the training part.
Okay. And can you tell us about your next stages of research? Is Charlie still receiving training? So
Charlie right now is not receiving training because he's in this waiting phase. This patient will be tested in a couple of months, I guess. Again, a visual assessment to evaluate how stable the improvement is, and whether we should start some sort of maintenance training that would, for example, happen once a week or so, or once every 2 weeks. This needs to be decided. We need to find out. But for now, this patient is in the follow-up phase, I would say.
Terrific, thank you. And I think that's the end of our questions. Thank you all for your terrific questions today. And I hope everyone has enjoyed today's behind the scenes presentation. It's important to us at the Foundation that you have the opportunity to discover how your generosity fuels so much great work at our hospitals and the impact you're having on people's lives every day. A recording of this presentation is available on our YouTube page, the Foundation YouTube page, and it will be available immediately following this presentation. Should you want to view it again or share it, we'll also be sending a short survey around to our participants, and we'd really appreciate your feedback. For those interested, we'll be hosting our 4th COVID-19 virtual Q&A next Thursday, May 28th, from 3 to 4 p.m. The invitation will be emailed soon. Please keep an eye out for the details. And thank you once again for being here. Huge thanks to Dr. Michael Reber and Dr. Valerie Wallace for joining us today and for sharing your incredible research. And we hope that all of you stay well, and hope to see you all again soon. Thank you.
Thank you. Thank you very much.